Line. Okay. Restart. Okay. Bismillah ar-Rahman ar-Rahim. I think we're going to start this webinar. It's going to be a series of webinar, and it's mainly about Accurate New 2. And I would like to, on behalf of Dr. Wael Qashqari, the president of SASIS, the Saudi Arabian Interventional Cardiology Society, to welcome everyone and to thank the National Heart Center and our society, SASIS, for organizing those webinars. And we thank also Boston Scientific for their cooperation. And I would like to welcome our participant and audience. At the same time, I think I will appreciate the presence of all our speakers before everybody else. And I think for the sake of time, this webinar is going to be a series, as I said, about Accurate New 2. And just to save more time, we're going to start with a presentation by one of the Boston Scientific representative, Hala Jandali. She will talk to us about Accurate New 2 valve system overview. At the same time, I would like to thank our friend, Dr. Saib Khojali from UK. Hala, go ahead.
Assalamu alaikum jami'an. Good evening, everyone. I'll share my screen. So can you see my screen?
Yes, make it bigger.
Yes. So assalamu alaikum. Good evening, everyone. I'm Hala Jandali, Clinical Sales Representative for Structural Heart at Boston Scientific. It's my pleasure to take you over the TAVI platform, the Accurate New 2 aortic valve system, as long as its accessories. So we're going to go through the Accurate New 2 TAVI platform, the 14 French eye sleeve introducer sheath, and the Safari pre-shaped wire. Starting with this small animation for the demonstration of the Accurate New 2 valve, in which it explains the deployment of the valve. As you can see, the Accurate New 2, what differentiates it from other self-expanding valve, the way that it gets deployed. It deploys from aortic to ventricular, which is also known as the top-down deployment. And this results in stability, no change in hemodynamics, and no pacing is required during the procedure. Moving next, we're going to talk about the features and the design of the valve. So as we mentioned, the accurate NEO2 is a self-expanding valve. Starting from the top, we have the stabilization arches, in which it's considered to be the self-centered feature of the valve. Its main goal or main benefit of this of the stabilization arches is the axial alignment within the native annulus and facilitation of coronary access for future intervention. Moving to the supraannular valve, it is made of porcine pericardium leaflet with the BioFix anti-calcification technology. This technology results in large effective orifice area and low gradients. We also have the upper crown, in which the upper crown sits on top of the native leaflets. It traps the leaflets away from the coronary ostium, and its main feature is to anchor supraannular anchoring. And lastly, we're going to talk about the lower crown, which the main feature of the lower crown is minimal protrusion into the LVOT that results in low risk of conduction system interaction. Another feature we have with the accurate NEO2 is the active PV seal technology, in which its main goal is to prevent the leak around the native valve, reducing PVL and resulting in single-digit PPI. As you can see in the screen, here the skirt is actively sealing during each cardiac cycle. The accurate NEO2 valve comes in 3 sizes: the small, medium, and large, in which it accommodates the aortic annulus diameter from 20.5 millimeter to 27 millimeter. And all three valve sizes are compatible with one transfemoral delivery system. Here we have the delivery system of the accurate NEO2 valve. Another benefit, other than it is compatible with all 3 sizes, it's its flexibility, in which the accurate NEO2 delivery system is considered to be a very flexible delivery system, and suits horizontal plus tortuous anatomy. It's a 2-step deployment stages, in which it consists of 2 knobs: the first rotation knob, and the second rotation knob. In the first rotation knob, we have the unsheathing of the upper crown and stabilization arches, and the second rotation knob, it unsheathes the lower crown, or the valve is fully released. We also have a safety feature, which is the safety button. And mainly the safety button, it prevents the physician or the operator from opening knob 2 before knob 1 during the procedure. Now we're going to talk about the 14 French eye sleeve, which is the introducer set that is used with the accurate NEO2. It is considered to be an excellent sheath with excellent hydrophilic coating and hemostatic valve sealing. The minimal vessel indication for the 14 French eye sleeve is 5.5 millimeter. And it also includes another feature, which is the responsive trifold expansion, allows the sheath to expand from 3 sides, suiting the true anatomy. And lastly, we have the Safari pre-shaped guide wire, which is the best wire to be used with accurate NEO2 due to its stability and support during the procedure. Also comes in 3 different loop sizes: the extra small, the small, and the large. Thank you.
Thank you very much, Hala. I think I don't want to spend too much here, but I can tell you from our experience, not because we are with Boston, but to be honest with you, when we compare sheets, I found out that I sleep one of the very nice sheet in the hand of interventional cardiologist. I don't want to mention anything about other company, but it's very easy to use and it's very safe sheet. The limitation we had with the Safari wire, it's the sizes, and a lot of time we run out of it, especially when we ask for not the small only, the extra small. It fits a lot of our patients. Just I think again, I thank you again, and we're gonna move to the first presentation by Dr. Saleh Khoj. Saleh, right? Saleh Khoj from Mecca.
Yes. Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everyone, and I would like to thank the organizing committee for having me. And I'm going to go over a case. Bismillah ar-Rahman ar-Rahim. This is a 93 years old female patient known to have ischemic heart disease, multiple prior PCIs. She had PCI to the LAD, diag, RCA in 2019. And she came back with a non-STEMI 3 years later and found to have an instant restenosis of the LAD with significant plaque into the diagonal and treated with drug-coated balloon. So this is her right coronary angiogram showing patent 2 stents proximal and distal RCA. And this is the left system in the coral view, showing a subtotally occluded ostial large diagonal and a significant ISR in the LAD. Moving to the cranial view, same finding, subtotally occluded instant restenosis in the LAD. So this has been treated with multiple balloon inflation, cutting balloon, and drug-coated balloon with a reasonable results, obtaining TIMI3 flow. Patient went home. A few months later on, came back with heart failure symptoms, and we did check her coronaries, which showed patent coronaries, and her echo showed severe aortic stenosis. This is her parasternal long axis view showing a restricted leaflet of her aortic valve with some calcification with high gradient across the aortic valve. Moving to the CT scan, which showed, this is the annular measurements, both in systole and diastole. So her area is 286, which is a very small annulus. Her perimeter is 62. Her perimeter derived is 19.8, which is very small. So this annulus can fit. This lady is having significant coronary disease with prior stenting and some ISR afterwards. So we need to preserve her coronaries. Although she's 93, she's functioning very well. She has a good functional status. So if you want to choose which valve platform based on this annular measurements, a Sapien or a balloon expandable small size 20 can fit. However, we might end up with high gradient in such anatomy. Also, a long frame self-expandable valve might give us good hemodynamics, but may be challenging in coronary access. So this is the reason why we have chosen the accurate neo valve. Moving to the LVOT measurement, it's a little bit smaller than the annulus. So the area is 245. The perimeter is 57 only. Sinuses of Valsalva around, the mean is 25 and 26. Coronary, so the left main height is 7 millimeters from the annular plane. The RCA has no major issues. The height is around 12 to 13 millimeters. STJ is fine. These are the coplanar and the cusp overlap angles on the CT scan. Moving to the peripherals, which showed adequate size peripheral with no major calcification. We can see some calcium at the iliac, but non-circumferential calcification with adequate diameter more than 5.5. This is the sizing chart. So we went with a small size 23 valve. This is the first shot in the coplanar angle, showing the three cusps well aligned. And then we pre-dilated the valve, which is routinely recommended to do a adequate pre-dilatation. We used size 18 millimeter balloon, which goes with the mean diameter of the annulus. And then moving to obtain commissural alignment, which we routinely do in all of our TAVI patients. Special steps should be obtained in this valve. So number one, you need to keep the safety button at 6 o'clock pointing downwards. And moving to step 3 rather than step 2, I usually go for the cusp overlap view first. And I need to see the free cell on the inner curvature. Then I go back to step number 2, which I need to see both the free cells are equally on the inner and the outer curvature. And then if I'm happy with the alignment, I go ahead and open the valve. So again, 6 o'clock, the button, safety button, go to the cusp overlap, and I need to see the free cell on the inner curvature. If it is not there, then I turn the delivery system and I rotate it until I get it on the inner curvature. Finally, I go to the cusp over the coplanar angle, and I need to see both free cells on equally on both sides. So this is our cusp overlap, and you can appreciate the free cell on the inner curvature in the cusp overlap view. Then we go to the coplanar angle before we start deploying our valve. And again, you can see both posts are equally on the right and the left side of the valve, starting to open the upper crowns in this view. And we are happy with the landing zone. You can see the dot of the valve is at the nadir of the cusp. Then we move forwards and do more. We open the valve more until we see the stabilizing arches. Then we go for the final release. And we get a good height of the valve. We can see the coronary filling, and we don't see any paravalvular leak. This is the echo post procedure, showing a well opening valve. Mean gradient post TAVI is 10 and no paravalvular leak. So my only take-home message is tailor your valve choice based on the patient anatomical and clinical characteristics. And thank you.
Thank you very much, Saleh. That was a beautiful case and a very elderly lady, 93. And just when Dr. Saib asking us what ages we have in Saudi Arabia, I mentioned 90, and we start with 93. What do you think is the difference, Dr. Saib, between this lady, 90, Saudi, Arabic, like anatomy-wise, and the 90s in your country now, in Western Europe or UK?
Yeah, I think, to be honest with you, there's a variety of 90-year-olds. There are 90-year-olds going on 70, and there are 70-year-olds going on 120. So, but the main
Sure.
thing here, which was very well demonstrated here, is that it's a female. They often have small annuli, and you know, it's very much a judgment call that we make, isn't it? The frailty, you see the patient, you see them walking into clinic. So I don't think there's much, you know, I think there's genetics, I'm sure, You know, I quite often see my patients. My oldest patient that I've treated is actually 99, and he's a jazz singer. He's a jazz singer, and he's still doing jazz now after his TAVI. And I don't know what they do, what water they drink or what it is. So I don't think there's much difference. I think it's a judgment, every patient on their own merits. But this is a typical case where a small annulus female, which is the majority of patients, in fact, and they don't do well with a lot of other, they don't do well with surgery. And this is a really good choice. It's a brilliant case to present. Excellent case.
Beautiful. Very nice. Thank you very much, Saleh. We're going to move to Dr. Talal Jabbari from University Hospital, King Saud, Riyadh. Talal.
Thank you, Dr. Balghaith. If you just allow me to share my screen first.
Sure.
Yeah, thank you very much. So I would like to thank the organizing committee for this kind invitation. Also, I would like to extend my thanks to Boston Scientific for giving us such opportunity to present in this webinar. So I'm going to present a case today that I think I'm hoping that will be interested and is going to generate a rich discussion. So this is my disclosure. So this is our patient. So basically, this is a 72-year-old lady. She's known to have hypertension, dyslipidemia. She was seen initially in a pre-op clinic for a pre-op clearance as she was scheduled for ventral hernia repair. So in further history, a patient status that she has exertional dyspnea with minimal exertion. It was in YHA class 3. Her medication at that time, including amlodipine, atorvastatin. In physical examination, you can see her patient was short. Her height was 155 centimeters, but her weight was 96. So she's morbidly obese with BMI of 40. And in auscultation, she had a significant murmur in the aortic area, consistent with severe aortic stenosis. Her lab at baseline showed hemoglobin of 120, creatinine was normal, and her baseline BNP was around 5,000, which is high. This is her ECG baseline, showing normal sinus rhythm with an auricularis complex. We did an echo to rule out aortic stenosis, and as you can see here, there was evidence of severe aortic stenosis with mean gradient 42. Her aortic valve area was 0.6. She had mild aortic regurgitation, but normal LV function. So she was discussed in our heart team meeting because she's in her 70s. She was seen by the surgeon. She was deemed high surgical risk because of her weight. And at that time, we decided to proceed with TAVI workup. So she had her coronary angiogram. As you can see here, the right was okay. In the left, there was just mild disease on the circ. However, on the LED, you can see there was some disease in the proximal, but there was severe lesion in the mid segment. You can appreciate this here. Her TAVI CT, it did show an aortic annulus perimeter of 66, which is small. The area was 326. The sinuses, the average sinuses was about 26, and the STJs was 23. And the height of her sinuses was around 60 millimeter. This is just showing the aortic valve calcification. So you can see there is only mild calcification on this valve. However, if you look to her coronary height, you can appreciate that the left mean was low, was about 7.3, similar to the previous case. However, the right coronary height was adequate, around 12 millimeter. In terms of the axes, you can see it was adequate. There was some mild tortuosity, but there is no calcification. So here, so our patient here highlighted a number of issues that I think we need to think about carefully. We need to discuss and digest in order to plan our TAVI procedure. So this patient has small annulus. She is morbidly obese, so there is a risk of patient-procedure mismatch here. She also has a low left main disease, so there is a risk of coronary obstruction. And also she has a significant mid-LED lesion. And it's very important here to decide on the optimal time of revascularization, whether you do it before, after, or during the procedure. And if you're planning to do it after TAVI, it's very important to think about the device that will allow you to have an easy coronary access. And if you look for all these features, it's probably accurate neo valve is the valve that you have to use in this case, because it's provided with supraannular hemodynamics, so it will reduce the risk of patient-procedure mismatch. It also has a short frames and reduced risk of coronary obstruction because of the low left main. And in this case, we decided to leave the mid-LAD lesion after TAVI because patient had no symptoms. There was no angina, and because of the location of the lesions. The lesion, it's in the mid-LAD, so it's not prognostically significant. So it's very important here to have a platform that allow you to have an easy coronary access. So we decided to use an accurate NEO2, and based on the CT analysis and the parameter, we use accurate NEO small, which is 23 millimeter. So here we went right femoral. This is the initial coplanar view. We did pre-dilate the valve with a 20 balloon, and we took a picture also here, very important to reassess for coronary occlusion. And you can see here, there was a good flow to the left main. And then we brought the valve in, and here we positioned the radio-opaque marker at the nadir of the coronary cusp. Here we opened the upper crown. We took pictures just to assess the position. And then we opened knob 1 completely with the stabilizing arches. We were happy with the position, and then we went and released the valve. And as you can see here, the valve was in a good position. The coronary artery flow were not compromised. We removed our wire, and then we took our last pictures, and you can see there was the valve looks well expanded. There was no aortic regurgitation, no PPL, and coronary flow were not compromised. This is her post-TAVI ECG. You can see it's remained normal sinus with no recurrence complex. We did an echo at the end of the TAVI procedures, so LV function was normal. The mean gradient was 12. Ideally, we like to have a single-digit mean gradient. We thought about post-dilatation in this case, but I think because of the small annulus, we thought like there is a risk of annular rupture if we post-dilate with a 20 balloon. So we decided to leave it as is. Patient had an eventful hospital course, and she was discharged next day. She was seen at 1 month and 6 month follow-up, and she was doing well with similar gradient on follow-up echo. Thank you very much.
Thank you very much, Talat. That was a beautiful case, and same small annuli, both patients, both ladies. And you explained the rationale and what problems could face us as operator, especially for those cases. And I think this valve fit them all, like both annulus, they did very well. In spite of low left main to the annulus or cusp distant to about 7 something. And I think you don't need to protect, or some people they might use protection like wires or a balloon. Or what do you think, Dr. Saib? I don't think they are wrong. If they have a doubt, why not?
No, exactly. And I think to a certain extent, it depends on your confidence with the valve and how much you've used the valve.
Yeah,
I think you've demonstrated actually more than one thing. Small annulus, very topical, especially with the new smart data. So supraannular valve, self-expanding valve. Secondly, low coronaries. And the third thing, actually, which you did, you made it look very easy indeed, is horizontal aorta. That was a horizontal aorta.
It is horizontal. Yeah. Absolutely.
So nothing there. So I think if you're really low, I mean, I've done coronaries at 4.5 millimeters, which is very low. Then I might just put it in just for my peace of mind, if you like. But if you're confident with the device, you don't need to, because you know how it works. You can go low down. The unique characteristic of this valve, which no other valve has, is the leaflet isolation mechanism. The upper crowns, they come out, and you're isolating this as long as you observe all the rules. The wires at the apex, there's no movement, last movement is forward, etc., etc. So I think you demonstrated that very well indeed. So yes, in this case, I wouldn't put coronary protection. And the choices are what? Are accurate NEO2. It could be another self-expanding. It could be Navitor. It could be Evolute. And Navitor will be easier because they're bigger cells. Evolute is a great valve, but at the same time, then I would be more likely to put a coronary protection. But with this valve, I probably wouldn't.
Absolutely. And I think in both cases, we could see the stability of the valve. in spite of all this, it is one of the most stable platform in the market. And since we use it, I think we are having maybe one of the lowest mobile type of platform. You know, we struggle with some of the companies, but I think all of them, they recognize this. And we see with the new generation, the stability even in other forms where we had some problems in the past.
Can I just add one
I
more
think-
thing? Well, just one
Sure,
point.
go ahead.
The post annotation, which is a really good point, and I agree with you completely that ideally you want single digit. So what I tend to do if I get a 12 and it looks beautifully expanded in 3-cusp view, go to the cusp overlap view and use the same balloon. I always use the same. I've just done a live case to Oxford actually. Use the same balloon you use to pre-dilate. When you've used the balloon, you've inflated it and it's actually unwrapped, you can get more than the 18. So if you use an 18, it may be 18 and a half, 19, and then you're less risky. You're not trying to blow the valve apart. Do you see what I mean? So it's worth doing that.
Mhm.
You might find it just makes a small difference, just getting the upper crown a little bit, and you find the gradient actually comes down quite a lot. It's just a thought that, you know, often using the same balloon you've pre-dilated can make a big difference. It opens up more than when you first open it up, if that makes sense.
Makes sense.
I think all of us, we share the same idea. You don't want to over expand such a small diameter lumen. You don't want problems because you were satisfied. You finish the case, it's just the gradient, everything is okay hemodynamically. And if you are eager to do something, I think the same balloon, don't change if you have to. Now, for the sake of time, we're going to move to the third speaker, Dr. Abdulaziz Al-Githami from our center. We work together and we have good experience so far with Accurate New2. Abdulaziz, floor is yours.
Thank you very much, Mohammed, and thanks for the organizer for inviting me for this webinar. Congrats to the previous speaker for their great cases. We will also present a good case, will generate some discussion about what to do or how the best approach to do. This is a case of severe AS with small annulus and ostial left main disease.
Can you share the slides, Abdulaziz?
Yeah, I thought I shared it.
تحت بالأخضر. Okay, yes.
Okay.
Excellent. Perfect.
So the agenda mostly to present the case and see what's our primary goal and what's the area of focus and the procedure, what we did in summary, what we learned from that case. So the case is the 84 years old patient who's a hypertensive with mild CKD. His baseline eGFR is 56. He's non-smoker. He works in a mosque and he's legally blind with limited mobility, walking with a cane short distance. And he presented actually with shortness of breath and chest pain, angina-like symptoms. His echocardiogram showed severe AS with preserved LV function. This is his echocardiogram showing the normal ejection fraction at the short axis, the velocity above 4 with a beat gradient of 70/40. The calcification of the aortic valve is seen, as well as the mitral valve had no significant regurgitation. His angiogram, as you can see, is showing a mild to moderate disease in the RCA. He does have an ostial lesion on the left main, as you can see in the third chart to your right, as well as a moderate disease in the middle AD. The caudal fuse at the bifurcation seem to be not intact, but definitely there is a severe disease of the ostium of the left main. So in this case, he's 84 years old. Our primary is to repasteurize him because he have an angina, of course, and also to intervene on his aortic valve. So as usual, we discussed him in the combined meeting, and due to his age and more comorbidities, we thought TAVI and left main BCI is the way to go. So his CT angiogram was an annulus with perimeter of 71. His area was about 385, with the mean diameter around 22. His femoral arteries seem to be adequate with 7.2 millimeter. There's some tortuosity in the left femoral. The coronary heights, mostly the left main with concern about where he had an ostial lesion about 13 millimeter, and as well in the RCA is about 16. The sinuses was added by CT more than 27. So our areas is to see the ostial left main does not seem to be have a lot of calcification. Definitely there is a damping in the pressure and it is tight. How we are going to revascularize it, pre or post, putting in mind that he does have a normal LV function. Also, to consider the aortic valve is a small annulus. It's not as small as previous cases, but still considered in a small range. Self-expanding valve probably is the way to go to improve his hemodynamics. We have to think about the coronary axis because this patient needs to be revascularized, especially for his left main and in the future for possible coming back. And what about the cerebral protection? And we thought about this in careful details, and we thought, given that he does have an ostial left main, that we might have a problem with wire, it's better to do him normal LV function support to go without any support, and given that it does not involve the bifurcation, probably implanting the stent at the ostium will be sufficient and will be easy to do without having a problem. And we thought to do it pre TAVI and watch him for a couple of days, then we do the TAVI. For the aortic valve implantation, definitely we wanted a self-expanding and the coronary axis, and we thought Boston Scientific is the best. The cerebral protection, we did thought about it, and given that he is, it's more kind of, we're connected that he's a Muslim imam and he's also kind of blind. We didn't want to risk having a stroke with him in 85 years old, so we elected to go with the cerebral protection. So we did the pre-dilatation for this case, and definitely we implanted the drug-eluting stent 3.5. Definitely the procedure has to be quick and sufficient to have a perfusion without significant ischemia with a patient who have severe AS. Then we dilated, and we did had a caudal view showing a good expansion of this stent in the left main. And there is no more damping the pressure, as well as we left that mid or proximal LAD, that's moderate disease as it is, because we didn't know that it is significant to intervene on at this stage. Then we, after a couple of days, we kept him in hospital because this patient actually from a long distance from home, it's having him to coming back blind, and it's a little bit more kind of on the patient harder. So after a couple of days, we did the TAVI, we implanted the cerebral protection device. Then we did with the pre-dilatation, as my previous colleague explained, with two 20 millimeter balloon. Then we did implanted the valve that steps as previously shown by other speaker. And the final result, as you can see in the right-sided last shot, showing no significant regurgitation. And you can see also the left main is being intact, and it's above the inner crown of the Boston Scientific. So post procedure, definitely he had still normal ejection fraction. The peak gradient over mean was 10/5. There is a trace to mild paravalvular leak. His ECG didn't change with the left axis fascicular block, same as previous before the procedure. And we were happy about the result, and patient was discharged. So in summary, this patient is a small annulus treated with self-expanded valve because of better hemodynamics. Coronary access is an important consideration, especially for this patient. We had an ostial left main, and we still stent him. And the careful consideration for the selection of valve is important. This patient is being followed, and actually we did him in January 2023, and now it's almost about 18 months, but last time I saw him in March this year, 15 months, and he's doing very well. Thank you very much.
Thank you very much, Abdulaziz. That was a nice case, and I think I still remember that case. He did very well. Yes, I agree with you. I think there was few issues, especially when you have coronary artery disease And I think our practice changed a lot, to be honest with you. In the old days when we started the program of TAVI, maybe a lot of us, the vast majority of interventions, we tend to do the angioplasty before and as a routine. Then what some data showed, and we changed this practice. We will not intervene unless it's a critical and very proximal, or the patient ischemic. Otherwise, if it is like mid or distal, we leave it. We don't touch it anymore. And I will take this to the UK people. What do you do nowadays in UK with whatever contradicting data we have?
Yeah, I mean, I think to be honest with you, we've got lots of meta-analyses and so on showing coronary disease, what you can do with coronary disease. And the truth is, yes, you can treat them, but what we have learned is with critical left mainstem disease, in the context of critical AS, patients don't do well if you do it beforehand. In fact, they drop dead. You have a successful procedure, they could drop dead within 24 hours because you've got truly critical aortic stenosis. So, and there's no evidence really to show that that's better. I think, you know, in choosing different platforms now, we have a choice. We have the ammunition to be able to use different valves to try and prevent that problem with coronary. So in this particular valve, choosing this valve, you can do your commissurial alignment. You're not so worried about the left main. You can treat it later on or do it at the same time. Now, the only ones I've done, to be honest with you, is critical left mainstem with heart failure, intractable heart failure, and impeller-guided TAVI, and so do the PCI impeller after a BAV, et cetera, et cetera. So you can get into trouble. And I think your colleague actually very clearly demonstrated that you wanted to get in and get out as quickly as possible because you know that it can be very compromised by the fact that it's aortic stenosis. So there are still some people who do it. Certainly, most people now won't touch mid or distal disease. There's no need to. Even with angina, because patients can present with angina, that could be the AS. So you treat the AS first and see where you go from there. What is important, of course, is you don't jail those coronaries. So you're not using a valve which will make it difficult or preclude you being able to treat it easily later on for PCI. So in this sort of case, to be honest, I wouldn't, unless the patient was having active ischemia on the table or recent, you know, acute coronary syndrome, I wouldn't have treated it. Or if I did, I would have done it at the same time. It's not a right or wrong. I think it's, you know, it's an amalgamation of experiences, isn't it? I think that's the main thing. So, I think the majority of people probably wouldn't treat that there and then beforehand, either do it at the same time or after you've done the tabbing.
We did actually
Saib, you wanna
cases of that.
go ahead, Abdulaziz.
Yeah. So we did before that as well a case the same kind of sitting with Embella support a patient who have severe calcification and bifurcation lesion in a low EF. And it's a different sitting for each case. We do have actually a case we did it after as well, but this patient is a little bit, as I mentioned, it was an osteal disease. We do want to wait and later on we have a problem with kind of cannulation or wiring, or it looks like it's more kind of in the simple get in and get out because there is no significant calcification. So that's the main rationale behind it.
And this, and I'm not saying this is a criticism. I think it's what you're comfortable with, and also you have a feel for that patient. You have a feel for that coronary disease. I can look at an angiogram now, but you're with the patient. So I think, you know, there are cases, every case on their own merit. So this is not a hard and fast rule at all. But I think in the majority of cases we have, as Dr. Mohammed has said, we have changed our practices. Whereas initially we used to do an angiogram on everybody, et cetera, and then PCI if we need to. We've learned from that is that you don't need to. And there've been quite a few cases reported showing that actually when you've got very critical left mainstem disease and critical AS, they don't actually do very well afterwards.
Great, thank you very much. Good discussion. Let's move to Dr. Sultan Al-Ataibi from Jeddah Military Hospital, and he will present the fourth case of accurate NIU2. Sultan.
Yes, hi everyone. So I'm not sure, do you see my slides?
Not yet.
Okay, just wait a second. What about now?
Yes.
Yep.
Very good. Okay, cool. So thank you very much, everyone. I mean, I'm just bringing a case from our cardiac center in Jeddah, where we have a very well-established program for TAVI procedures in nearly all platforms. So this is a fairly old patient, 84 years old male, presented to us 3 years ago with an STEMI. We did an LED diagonal PCI. And he had a thickened aortic valve. Back then, it wasn't severe in form, but 2 months ago presented again with acute coronary syndrome and also with a left circ that we treated. But what was new that the patient developed a severe aortic valve stenosis and was pretty reluctant to go further with the TAVI. He was in dual antiplatelet therapy with a good ejection fraction and always blamed that on his prior lumbar disc surgery, but then came back to us with a chronic kidney disease with a fear of complication, but still having dyspnea, which is pretty severe with merely just moving around the block, no syncope as well. So I'll just show the last coronary angiography, showed severe diseases in the mid-distal. So this is nothing that we should work on, showing a plain and simple severe aortic stenosis with some mild AI. Went ahead with a heart valve team, of course, giving his condition, it was TAVI as a choice of therapy, but giving the chronic kidney disease, everyone was a bit hesitant to go further. So we completed the workup, nothing to worry about in terms of aortic valve. As you can see in the picture, calcification all over cusps. Good dimensions of the annulus. Any valve would work, a little bit horizontal aorta, but we checked everything, and this is what we should do in the LVOT, you know, just to give you a complete picture about what you're gonna face if you wanna put any valve from any platform. In terms of coronaries, that wasn't a problem as well. Everything was high and simple. Here is just a bit of preparation in what angulation where you should start with, but then we saw these foots and the limbs. We have a lot of calcification, tortuosity, so we decided that if we're gonna go in, then we need a valve that actually have a very good sheath, that's slippery, stable. Maybe sheathless valves would give us a problem. So we made a plan, which is what we do with every case. We will go right femoral artery and have a second axis at the left radial, a right ventricular pacing, what type of wire, that should be also in place. Appreciate, we would pre-dilate with a balloon of a 23, and we would choose an accurate NEO2. We would post-del if needed with the same balloon as a soft post-del, as a closure device, MANTA, and furthermost, and the most important thing is with minimal dye. So this was the pre-dilation, as you can see. It was pretty good dilated, no problems as well. Accurate was in after the cusp overlap. Showed pretty good results, but I can see in the angio here, we saw that at the left coronary cusp, there might be a problem, a small problem with the paravalvular. And this is when it comes to hand, when you have a good fully team compromising, you know, an non-invasive cardiologist with good echo, which showed us directly. We had a low 2 digits number, but some paravalvular leak. So we decided to post-del with the same balloon, which was pretty well established. The valve moved a little bit, as you can see, in the same direction, and no gradients. Patient did very well. ECG was fine. This was the echo post, showing pretty nice results. Axis was also good. So what did I say? Let's just move. So I think my learning point from this case, it's not a very complex case, but before doing any TAVI, I think you should plan ahead and look for what problems you might have and accommodate which valve. All valves platforms are actually good, but maybe one of them is actually better for this patient because of specific reasons. And if you have tortuosity, if you have small legs, maybe you need to do shock waves, you need to anticipate. But if you have some axis problems, then a peripheral balloon should be in hand, and you should know it from the CT in terms of preparation, in terms of what size, and this is how TAVI usually works, pretty simple and smooth, by having a plan before actually starting, and then everything would be easy and just, you know, as a part of your routine in the hospital. And the patients characteristic shouldn't be a reason not to do a procedure. It would give you heads up from before, but you should be quite ready for whatever might happen in the procedure. Thank you.
Thank you very much, Sultan. That was a very nice case, and I concur with you and agree 100%. If you plan the case in advance, good discussion, good plan, try to anticipate any complication could happen. I think most of the cases where we anticipate problems, they do very well.
Yeah.
And those patients where you know, I don't want to say anything, but sometimes, you know, it happened by chance or whatever, and you were not well prepared, even mentally. And I think with experience, a lot of problems, you could overcome it. Having some problems or complication, like in the beginning of TAVI, all over the world, because they started with the big sheets, they had problems. And the vascular complication was one of the major. That's why when Hala present the technology they have, I thought when I compare the iSleeve with other sheets, it's one of the best, to be honest with you. And Dr. Said, do you want to comment before you go to your talk?
Yeah, no, I just concur again, to be honest. I think a very important part of TAVI now we've learned is really we have a TAVI planning meeting and we go through the imaging and so on. And as you say, you need to anticipate, you have plan A and plan B. So I think if you don't plan, you get burnt, don't you? And I think, you know, I mean, vascular complication remains the Achilles heel of TAVI. But again, if you plan for that, you can hopefully circumvent quite a few cases and complications. So I completely agree. That's a very well described case where they thought about it. There's a lot of thought gone into how we're going to do this case.
We could see two cases tonight with the horizontal aorta, although it's not the bad ones, but 2 of 4 that tell you how often we see it. And unless it's very, very typical horizontal, the CT scan people and the people who are analyzing the CT will pay attention. Otherwise, you will recognize it in the cath lab. It is the same issue with the bicuspid valve in the beginning. We had a lot of argument between the functional, bicuspid, and we had one of the senior guys who was doing the echocardiogram. And I remember in the first year, we used to do a routine TAE. That's mean 13 years ago. And he tell us this valve is bicuspid. Although the CT scan people, they were still in the beginning, and we changed the protocol many times with the European, with the American. And all this, like the CT, to be honest with you, it doesn't help only the interventionists. Our colleague in the cardiac surgery department, they use the same data, and they get a lot of benefit, and they are trying to avoid the mismatch, which we have in a lot of our small, short ladies OPs. Because at one time we were doing like the same TAVI protocol for the sutureless valve and the TAVI. That's why they gain a lot of experience and they improve their practice. Now it's my pleasure to introduce our colleague, Dr. Saib Khojali from UK, and he will talk to us tonight about the data on accurate neo2.
Okay, so I hope there aren't too many yawns or anybody falling asleep now. So I'm going to try and make this as not exciting, but as hopefully entertaining as possible, and give you a summary really of what's going on. So let's have a look. I think this is it. Is that me? Can I share my screen? That's it. Share. I don't know if you can see my screen. Yes, you can. Great. Okay, so I think from a data point of view, I think what we need to do is concentrate what's happening now. Now, as we know with TAVI, we've got 3 different populations. We've got the very high risk, we've got the intermediate, and then we've got the low risk. And what we're going to go on to is here, the all comers is one thing. So I'm going to talk about accurate neo2, generally speaking, what we know so far with the all comers, but comparing neo2 to other devices, so self-expanding versus balloon expandable, and in particular Sapien. And then I'm going to talk a bit more about the more recent low risk trials, particularly ones looking at patients who are truly low risk, only low risk, and also looking at bicuspid, because the bicuspid story is not yet finished or told. So we're going to concentrate on PROVE, what PROVE means, comparing the self-expanding Neo2 versus the balloon expander, which is the Sapien 3, and then talk about Notion True, which is interesting and has been presented recently at PCR. I'm going to ignore the poster presentations for now, not because they're not important, but because I think we'll run out of time. I don't really want to speak for 15 minutes. That's a bit too long, and you'll get bored by the end of it. So there are quite a few studies, as you can imagine, and I don't want to blow you over, but if you look at all the way down this list here, multi-center trials, most of them are registries, of course. You can see the in-hospital mortality, 30-day mortality is not bad. It's pretty good and comparable to other studies. There's been a big change in Neo2, and one of the things which were negative about Accurate before was the Accurate Neo. Now we're in Neo2. You'll see from this picture here, I'm not going to go into too many technical details because Hal has done that very nicely, but the difference basically, there's the skirt. I don't know if you can see my marker there, and that's the deeper skirt. And that makes a big difference, internal and outside, which has reduced the paravalve leak really quite significantly. So it wasn't a bad valve, but the skirt wasn't long enough, if you excuse the pun there. Wasn't good enough. So there's quite a few studies, as I say, and I think when we look at studies, we look at them as multi-center, we look at them as prospective, we look at them as all-comer populations, which is important for us, and we also look at ones which are core lab analysis and randomized, and that's important.
Can you make the slide bigger?
Yes, of course. Sorry, is it not presenting? It's not presenting.
Yeah.
I apologize.
Yeah, presentation mode.
Oh, bear with me. Sorry, I thought it had been. Okay, can you see that now? Is that better?
Yes.
Okay,
Excellent.
apologies. Please forgive me. So as I say, there's multi-center, prospective, all-comer, and then core lab analysis with all imaging done. And what we're talking about is prospective randomized trials. So these are multi-center trials showing you the study populations. They're not massive, but they're big enough and showing you reasonable mortality, anything between 1% really and 3%. Now, I want to go through the PROVE study. This is important because this is looking at the Accurate Neo2 valve and comparing that as a supraannular valve and how it performs in a multi-center trial. This is mainly in Germany, okay? So, and the PROVE trial basically is looking at the efficacy of this device, of the Neo2, particularly in context of having had the previous experience of Neo. So it's a prospective, it's a multi-center, all-comer population with core lab analysis. It satisfies all those 4 criteria. And it's important because it's your normal daily practice. Anybody can walk through the door and need a TAVI. So it's investigator-initiated prospective trial, single arm, and 27 European cities of sites were used with 1,000 patients. And the primary endpoints are the usual ones: all-cause mortality up to 12 months, usually stroke, and looking at rehospitalization. And there are additional endpoints as well as VARC3 criteria: technical success, device success, and clinical efficacy. So there are quite a few centers. From a baseline characteristics, they're pretty well the standard. As you can see, the average age, particularly notably, is 82 years of age. Females are more predominant sex in this study. 65% of them are females. And the rest of the stuff is just normal. If you look at the bicuspid, there's only about 2.5% of that population were bicuspid. And these are the data which you can see there. So there's pretty typical baseline characteristics. And those are the things I've just mentioned. The Accurate Neo size in this study, which was used, interestingly, the general anesthesia was used in 11%, which is quite high. For us, general anesthesia in our practice certainly is much less than that. It's probably about 3%. And transfemoral access was 99.9%. So they must have done some transfemoral access with GA, given those figures. They've used cerebral protection in a minimal number of cases, 2%, which is very... Pre-dilatation was very high, which is what's recommended by the IFU for Accurate, and post-dilatation was used in just under a third of patients. As far as the device not being actually implanted, 1.9%, so just under 2% not. Second valve, only 1%, and conversion to open surgery was 4 out of 1,000, which was 0.4%. If you look at the sizes used, the most commonly used size is the medium size. Okay, about 40% of those patients needed a medium Neo2 size, and the rest were divided into sort of thirds, really. The all-cause primary endpoint, 30 days, is low. It's good. It's low. All-cause mortality is 1.4%, and there's a split there between cardiovascular, non-cardiovascular, and also the unknown ones, which we can't determine. That's at 30 days. So that's the PROVE. So overall, the key clinical things that we can take away, or takeaway points here at 30 days, is that we've got a very high technical success rate, 94%, device success 88%, and early safety 80, just under 80%. And actually, if you look at that, major vascular complication is low, 1%. Severe bleeding is low, 2.6%. and acute kidney injury is low as well. Pacemaker rate, 9.3%. In our practice, it's about 6% actually, and we use quite a lot of NEO2, but that's variable depending on your cohort. You maybe use doing TAVIs on patients who got lots of right bundles, so you have a run of those. So, but on average, it's about 9.3%, which was found in this study of 1,000 patients. And stroke rate was low as well, 2.2%. As you'd expect, the gradients come down nicely, and at 30 days, down from mean gradient of 30 down to 6.8, and the effective orifice area goes up to 2.1. Only 3.4% are moderate to severe, moderate and severe. So the rest is mild or none to trace. So more than 80% of patients, almost 90% of patients, 97% of patients actually will have either none or mild PVL, which is a very good performance, especially compared to previous year, and very comparable to other devices as well. So these are the approved registry in this all-comer population, which is good overall. So that's the takeaway really from that. Okay, so good numbers for this approved study. Now this is an important study, which I think is important to bear in mind, particularly if you're a center that uses a lot of balloon expandable, because it actually shows 1-year outcomes. And what we've learned actually, 30-day outcomes are good as a start, but we really do need the 1-year outcomes. And in fact, we've learned also from the SAPIEN 3, part 3 data, the 5-year outcomes, that actually things can change. So whilst the 1-year outcomes would look good for SAPIEN 3, the 5-year didn't look as good, and there's a crossover in the curves, as you might have noticed, published or rather presented last year at TCT. So this is a comparison between the NEO2 and the SAPIEN 3 Ultra valve. And this is again a head-to-head comparison, hasn't been done before. This is to really help us determine whether you could use this valve. Why could you not use this valve as opposed to a SAPIEN 3? Because there's no data. Okay, well now we need data, and this is the head-to-head comparison. So the previous studies have looked at it versus balloon expandable SAPIEN 3 Ultra, and this is but in the early stages, whereas this is 1-year outcomes. And actually, there's no midterm data at all, and this is scope 1 3-year data, which is not great and not believed because it was a different valve. But this study actually was important, and it was executed because it was a good and first between 3 different heart centers in Germany, looking at this direct comparison between a self-expanding NEO2 valve and the SAPIEN 3 Ultra. It was basically propensity score matching and very well followed up with 1-to-1 propensity matching. NEO2 versus SAPIEN 3 Ultra. Primary endpoints was, as usual, will be in hospital all-cause mortality, stroke, and rehospitalization. Baseline characteristics, all very similar, really. The only thing I would say is actually you can see the p-values there is that, the difference in females, again, is higher. In the NEO2, high number of females have the NEO2 as opposed to the Ultra, which is a potential criticism. The rest really is, is within the realms of baseline characteristics, but well adjudicated. The results, really, the procedural data and in-hospital outcomes were generally good. What's interesting, actually, is NEO2, as we know, needs to be pre-dilated in all cases. That's the advice. And in 95% of cases, that was the case here. Whereas, of course, with SAPIEN 3, it's rarely used, and only in 1/3 of patients did they pre-dilate. And post-dilatation is not necessarily needed with NEO2, but was used in about 37% of patients, and with Ultra in about 13%. Technical success was interesting in that they were both equally successful. Device success at 30 days was interesting because there was a significant difference here, with a lower device success at 30 days with the Ultra. And the mean post gradient again was significantly higher with the SAPIEN 3. The aortic valve area post was also significantly higher, or rather higher with the NEO2 as opposed to the Ultra. So there are some differences which were quite remarkable. I think from the primary endpoint point of view, there was no difference in mortality at all. 1-year mortality was very comparable, no significant difference at all. 1-year stroke, again, no significant difference at all. And 1-year hospitalization, there was no difference. So all in all, this is showing us actually that they're pretty comparable. Primary endpoints, there's no real difference. Those curves pretty well follow each other, NEO2 versus SAPIEN 3. So the obvious question is, why can we not use it? This is for both deaths, the primary endpoint, which is death, stroke, and rehospitalization. So why is it important? It's important because actually what we're saying is we need another tool in our toolkit. And NEO2 is a very good tool for that toolkit because it's self-expanding. It can be used in low coronaries, it can be used in small annuli, and it's actually directly comparable to the SAPIEN 3, which has downsides to it, particularly in small annuli. in patients with small annuli, and also not as good hemodynamics through the valve itself. When you look at the echo, looking at effective orifice area, patient prosthesis mismatch, etc. So if you've got similar results with both platforms, then why not use one over the other, particularly if you've got specific anatomical requirements? And that's very important. This obviously needs to be confirmed by randomized data and long-term follow-up. And we know, as you know, there's going to be there is the IDE study, which should be coming out hopefully later on this year, which is a proper randomized controlled trial. So the essentials to remember: midterm outcomes versus ultra are unknown, but 1-year outcomes we know are pretty comparable, but we need randomized controlled trials. The comparison is the first time it's been compared directly at 1-year outcomes. We've never had that before. It's a multi-center retrospective analysis with one-to-one propensity score matching, and that's the downside, because like all research and studies, there are criticisms or limitations, and that's the limitation of this study, but it's the best we've got so far, and we will be getting randomized controlled data as well. Okay, so it's important. It's 1-year results suggest that 2 platforms may be equivalent and alternative for a tailored differential valve selection, so you can choose your valve, and you'll be justified in doing so. Okay, so current randomized controlled trials, we know you know all about them: Notion 1, Partner 3, eValuate low risk, Dedicate. But we haven't had a true low risk surgical trial. We've had the low risk pulled out of other trials like intermediate risks, CERT-TAVI, etc. We need a low risk trial which also doesn't exclude aortopathies. As you know, Partner 3, eValuate low risk, excluded those aortopathies, the more complex, the bicuspid story, which we don't know the end of yet. So Notion 2 was a good foray into that, really. So this study was a 1-to-1 randomization, looking at bicuspid as well as tricuspid valve, and it was just low risk surgical patients, so under the age of 75, under or equal to 75 years of age. TAVI versus SAVA. These are the numbers with intention to treat. There was some crossover in the study, so 187 TAVIs, 183 surgical, 2 from the TAVI crossed over to surgery, and 9 from the surgery crossed over to TAVI. So in the end, we had 194 TAVIs being done and 176 surgical being done. Primary endpoint, the usual composite death, or the composite endpoint of death, stroke, or rehospitalization. And rehospitalization includes not just heart failure related, which was what the case was with previous partner studies and eValuate, but valve as well as procedure. So being hospitalized for any of those. And then there are secondary endpoints as stated there. This is important. The study baseline characteristics were lower, typically low risk. You can see there it's remarkable to say TAVI and surgery, the mean age 71.1. Okay, we've got no 80s here. We've got proper low risk with an STS score was 1.1 for each. Bicuspid aortic valves, it was 26% in the TAVI group and 28% in the surgical group. So it's good representation across them. So the results were interesting. Again, no significant difference in death, stroke, or rehospitalization. Okay, which is important. And this is low risk trials. So and death or disabling stroke, again, no significant difference. Maybe slightly, the numbers are small. They're not massive numbers, but actually they're the best numbers we've got. And there is no significant difference in death or disabling stroke between the two. What is interesting actually here is that the one thing that was in this table, you can see one interesting thing is the non-disabling stroke, which is a bit high in the TAVI. And we've all had those where they've had a bit of weakness or lost their speech and then hopefully got it back again. But the disabling stroke, the bad strokes in inverted commas, were very comparable and not significantly different. This is important. These are key secondary endpoints. And I think this we know about. Major life-threatening bleeding, much higher in surgery. New onset AF, we know is higher in surgery, significantly higher, 41% as opposed to 3.2. Length of index hospitalization, we know is longer for surgery. And patient prosthesis mismatch, again, is higher in surgery. And we know that. And we've heard about the surgeons wanting to do a lot more aortic root enlargement. But actually, the one thing which, of course, TAVI does fall down on is new permanent pacemaker implantations. We have to be honest both ways. So it was higher, and that was just significant, 15.1% as opposed to 8. But it is notable that that's actually a lot lower than if you remember previous studies where we had pacing rates of 25% and 35% and even higher than that. We've got better at putting these valves in, and the valve technology has got a lot better. And again, moderate or more paravalvular regurgitation was higher with TAVI at 4.7%. These are simple representations again of NYHA from the patient's point of view, feeling better 1 month and 1 year. If you look at the 1 year, that's probably the most telling because you want to see how long this lasts really or how it gets better. And actually, it's pretty good. You know, it's very comparable. If anything, the TAVI may be slightly better, but not significantly so. And quality of life, again, at 1 year, exactly the same, no difference at all. When you look at 1 year between TAVI and surgery. Okay. Tricuspid and bicuspid, this is a different story, and this is interesting because I think it's the first time we've had actual evidence to show that actually, you know, if you look at the tricuspid cohort, there's no difference, no problem at all. Primary endpoint, no difference. But when you split it and you take the bicuspid, although it's not quite significant, it's 0.07, there is a less favorable outcome for TAVI, as you can see there, with bicuspids, which is interesting, isn't it? And it's not quite reached significance at 0.07, but it may well make us think again and maybe look at trials, design trials, to look at the bicuspid story and see where we go with that, because I think the surgeons are certainly better at shelling out that valve and stitching a beautiful new valve in, although we can get some very good results. And again, that depends on what type of bicuspidity we've got. Is it type 0? Is it type 1? Is it type 2? Death and disabling stroke, again, no significant difference between tricuspid and bicuspid. There's a trend towards, you know, the numbers are slightly higher with TAVI, with bicuspids, but actually not significantly different. And this is a good stride because it actually shows you from a tricuspid point of view, tricuspid aortic stenosis, that actually it's comparable, directly comparable. There's no surgery and there's no difference really between surgery and TAVI. It's right in the middle. I think for bicuspid aortic stenosis, it probably is tending towards surgery being more favorable, having more favorable outcomes. And we need to have proper randomized control trial with good numbers to really look at that. And I think one of the biggest things, if you look at down the bottom, there's a paravalvular regurgitation greater than moderate. You tend to get that more with bicuspids, and also the higher rate of death, stroke, or rehospitalization, which again can be related to the paravalvular leak. So why the study? This basically shows that this is the previous trials didn't include young patients truly and all through, and also excluded bicuspid. So that's why this study was very important. And actually, what it shows is the first ever randomized controlled trial comparing TAVI versus surgery in truly young aortic stenosis patients, and only young patients, and including bicuspid aortic valves, which is 26%, which is a good percentage, you know, a third of the patients, basically. So what do they tell us? They're basically equipoise, I would say, between TAVI and surgery in the overall study. I think that's pretty conclusive. The primary composite, that's for the primary composite endpoint of death, stroke, or rehospitalization. In bicuspid aortic stenosis patients, I think the outcomes were less favorable with TAVI, but I think that needs further study, and that will need a proper randomized control trial to look at bicuspid aortic stenosis and TAVI versus SAVR in that cohort of patients and the type of bicuspidity. Thank you.
Thank you very much, Dr. Saib. That was a beautiful overview for the available data so far. And I think with the German data of 1,000 people, with it showed a very good and promising result for this accurate NIU2. Like the mortality 1.4%, that's excellent. When we think about vascular complication, is it related to the anatomy? They have a bigger, you know, as a German, bigger vessels, or it's due to the sleep sheath. It's 1%. This is one of the lowest complication you're going to see in trials. And the pacemaker, we know some of the Boston Scientific data showed already 6%. With the German people, they showed like 99%. But I think it's still within what we see between 6 to 9 or maybe less than 9. Stroke still an issue with TAVR, but it's not that bad, 2.2%. The good comparison between the available Edward, especially Sapien 3 Ultra, now Resilia is coming, and we started already in Saudi Arabia. It showed a very good comparison, like there is no inferiority so far. The issue of bicuspid, still we face a lot of bicuspid, especially in younger patients with aortic stenosis. And I think younger age is still, I think surgery is preferable. For the elderly people, you're going to weigh the benefit and the risk. I think there was some questions here. I will read maybe. If you can open from your side, Dr. Marwan Gutov. Do you see the two questions still there?
Yeah.
And
so can you comment on the mechanism and clinical presentation of structural valve disease after TAVI on expanding valve accurate NIU2 or accurate NIU? I mean, I think structural Dilation is there are a multitude of ways they can present, and of course the mechanisms are twofold really. One is developing thrombosis, where you can get high attenuation leaflet thrombosis or valve thrombosis, and the other thing is you can get a leaky valve, which tends to happen with time. And this is the story of durability and what type of valve it is. Which happens with time, and we know that with some of the TAVI valves that we put in many years ago. I've recently done a case, a TAV in a core valve that I put in 12 years ago, and that was leaking. That was basically the aortic regurgitation. But in self-expanding or any valves really, I think the main structural valve deterioration will be due to halt or true valve thrombosis. I think that might be exacerbated in some valves, not necessarily self-expanding valves, when you've got patient prosthesis mismatch, you've got higher gradients, higher residual gradients and so on, because you're more likely to have earlier damage to the leaflets, as it were, with time.
Yeah, and I think the echo people, they have to make it very clear when they do the follow-up echo. If there is an increase in the gradient, that will raise the issue of halt, and you might need to do a CT scan and start anticoagulation, which is the best treatment. Yeah, go ahead. The next question, you want to read it?
Okay, also follow-up question related to PVL, paravalvular leakage in patients with aortic stenosis. How will the valve reduce the risk of mortality? Well, it does. We know that PVL makes a big difference. So what we do know is that if you have mild PVL with a self-expanding valve, certainly, that's not really, doesn't have a major impact on mortality. However, if you have moderate or more PVL, then that will have a greater impact. So you want to have the most perfect TAVI, obviously, that you want to, and I would not leave any moderate PVL at the end of a TAVI list, because that will have an impact on the risk of mortality. The good news showed that they showed in the study that in the ACN2 study that 3.4% of patients only had moderate or more. I hope that answers the question. Yeah.
If our colleague, the speaker, have any comments or anything, Sultan, other colleagues, and I think what we tried.
You allow me.
Go ahead, Abdulaziz. Yes, sorry.
So,
go ahead.
Just to go over the question regarding structural valve deterioration in the accurate neo, I think there is a study where it's an off-bench study looking at 1 billion cycle of accurate neo compared to surgical, and that's actually did very well compared to other platform as well. So yes, we didn't have a longer term of accurate neo because it's at least this last model or last version of it, but the previous ones maybe it showed some structural deterioration than others, but definitely the new one with this kind of studies didn't see much of structural deterioration noticeable more than other platforms.
We have another question. If you want to comment on that side, because you review some new data.
What is your opinion about accurate as a first valve in younger patients? Yeah, and that's yeah. So I mean, I think when we talk about younger patients, there are quite a few considerations, aren't they? The coronaries, they may have coronary disease later on. What valve are you going to put next time when that valve wears out in, let's say, 10 years' time? The third thing you need to talk about is pacemakers. Now, I've certainly, when we talk about young patients, we don't do the American way, which is 65-year-olds. We don't do those routinely. We do occasionally 65-year-olds because of comorbidities, but we don't routinely do that. But certainly for younger patients, this is not a bad valve. If you're going to do a TAVI on a patient, it's been discussed with the heart team, then as a first valve, it's not a bad valve to have, because what you've got is the benefit of both. You've got a stented, almost like a balloon expandable framework, but it's supraannular valve. You've got the coronaries isolated because you've got your upper crowns, and you've got superior hemodynamics through that valve. So I don't think it's a bad valve, which you could also facilitate putting in, if it does get SVD in due course, let's say in 10, 15 years, you could put a SAPIEN 3 in that, or you could put another valve in there. So I think it's not a bad valve as a first choice, to be honest. I think also the story will be told a little differently in a few years' time when we have more robust data on durability, because if the supraannular valves last a lot longer, then for younger patients, that's what you want. You want to get as long as you can with that valve before you have to have your next valve. So I would certainly think about that, and also the risk, of course, of pacemaker. Pacemakers are not benign, easy to put in, but they're not benign. So I'd want to avoid a pacemaker, and that's got a low pacing rate. Our pacing rate, as I say, is less than 6% with the Neo2.
Yeah. And I think pacemaker is still an issue, even with whatever technology and development we are doing, the change in the techniques, still we see it. We do cusp overlap, you know, the membranous measurement is very important, but it's still, in spite of that, sometimes even with the ballooning, you see those conduction problems, left bundle, and some of the people, you know, they turn to more bradycardia or heart block on the second day. That's why we have to watch the patient very carefully.
Yeah, absolutely.
And I think, yeah, it was a very good and nice webinar. We learned from each other, and we choose to have our younger generation, youngest interventional cardiologists to take the lead for tonight, and they did very well, to be honest with you. And on behalf of all the scientific committee and Boston Scientific, I would like to thank the National Heart Center, المركز الوطني للقلب, for organizing such nice webinar. And we will send, I think, the lecture to the emails of each one of you. At the same time, we would like to announce the second webinar, which is going to be on the 29th of June, inshallah. And I would like to thank everybody, the attendee, for although it's a weekend, it's a night time, and our speakers, especially our friend from UK, Dr. Saib Khojali, and my colleagues from Saudi Arabia. Thank you very much for everyone. Thank you.
Thank you.
شكرا دكتور محمد. دكتور خوجلي, الله يديكم العافية. Very interesting webinar, and as Dr. Balghaith said, inshallah the next one will be in June 29, and with a complete new group. So you guys, we want you exposed to different variety of experience. Thank you very much, and God bless you.
Thank you very much. Thank
Thank you. Bye-bye.
Thank you
Take
very
care, everybody.
you.
Thanks.
Bye-bye. Assalamu alaikum.
Bye.